now that we've reviewed the basics of quantitation in critical care cardiac ultrasound and the basics of Doppler, let's move on to probably the most commonly used arena for quantitation of cardiac function in critical care, and that's the quantitation of LV function, or the quantitative LV assessment. So again, quantitation in critical care brings you objectivity and an objective component to a subjective assessment. So like I said, largely, most of what we do in critical care cardiac ultrasonography can be done so qualitatively when it comes to guiding our management, but there are significant a subset of patients in whom getting a quantitative or an objective component is going to be helpful. When we're talking about LV quantitation, some of the most more specific context within which we would try to quantitate LV function would be to either predict a response to an intervention or titrate an intervention. Volume responsiveness is probably the most commonly used application for LV quantitation, where you're trying to at least initially predict volume responsiveness. Then once you've predicted volume responsiveness and started volume resuscitation, you can then subsequently use LV quantitation to measure the response to ongoing volume resuscitation. You can use LV quantitation to help you gauge the response to other things like inotropes, to diuresis, to vent changes like increases in PEEP. All these things help you get a precise, followable sort of measurement of how well or how poorly the heart and cardiovascular system are responding to your interventions. Okay. So how do we quantify LV function in critical care? There's two ways we approach it. The first one is the preferred approach, where we can actually measure or estimate stroke volume and cardiac output. I say all the time, we as intensivists are most interested in flow. And estimation of stroke volume and cardiac output using echo, that is the most sort of specific approach to understanding flow that we have, at least non-invasively. So if you can get the views to estimate or measure cardiac output, use this approach. If you can't get the views, there are some other approaches utilizing quantitation of ejection fraction that are sort of a poor man's approach to LV quantitation that we'll talk about at the end. Okay, but first let's talk about using Doppler to measure stroke volume. Because our cardiovascular system is a closed system, flow has to be constant everywhere. So you can really measure stroke volume anywhere in the heart, but the most convenient, the most reproducible, and the most usable approach, usable location where we measure stroke volume is at the LVOT. And that you will see lies mainly in the reason that you can actually measure the bore or the diameter of the LVOT. Okay, so what we do is we are using Doppler to estimate the flow velocity of blood moving through the LVOT during systole. Okay, and we utilize pulsed wave Doppler. So remember, the difference between pulsed wave and continuous wave Doppler is that if we're trying to measure velocity at a specific point, a particular point, we use pulsed wave Doppler. So in this case, we're trying to answer the question, what is the flow, what is the velocity of blood moving through the LVOT? So we use pulsed wave Doppler at the LVOT. Now, in order for us to use Doppler to measure stroke volume and cardiac output, there are two assumptions we have to make, and or two conditions that your heart has to meet in order to make this a usable modality. The first assumption is that the LVOT is a tube or a cylinder in shape. Okay, and most of the time that is true. The second assumption is that the shape, more specifically the diameter of that tube, does not change throughout systole. And most of the time that is true as well. The most conspicuous exception to this is in the setting of hypertrophic cardiomyopathy affecting the septum. If you have septal HCM, the LVOT by definition is deformed, so it's not tubular in shape. And especially in the setting of tachycardia, volume depletion, you have dynamic obstruction. So by definition, the diameter of that structure is changing throughout systole. So if you have hypertrophic cardiomyopathy affecting the LVOT, then you cannot use Doppler to estimate stroke volume. That's the most sort of common exception to being able to use this. In most other patients, you can use this to estimate stroke volume. The other exception would be is if you have significant aortic regurg, that will it will detach LVOT stroke volume from actual effective stroke volume. This is sort of what I'm trying to say. Okay. So you want to screen for both of those things before you use it. If you have severe aortic regurg, or if you have findings that are suggestive of hypertrophic cardiomyopathy, I have a separate talk on that, then this is not a method that you can use to estimate stroke volume. And pretty much everybody else, if you can get the views and get accurate measurements, you can use this to measure stroke volume. So here's the LVOT right here. So basically between the mitral annulus, which is here, and the aortic annulus, which is here, this is your LVOT, your left ventricular outflow tract. And if you can imagine in 3 dimensions, this is what it would look like. This is the tube that I'm talking about here, the LVOT tube. So we're trying to measure the velocity of blood going through that tube, or the flow velocity of blood going through that tube. And in order to do that, we're going to utilize Hagen-Poiseuille's law. And Hagen-Poiseuille's law tells us that the flow velocity of a compressible fluid moving through a tubular structure is equal to the cross-sectional area of that tubular structure multiplied by the velocity of the fluid moving through the tube. So blood is a compressible fluid and the LVOT is a tube most of the time. So we can measure flow velocity, and in physiologic terms, flow velocity is stroke volume. That equals the cross-sectional area of the tube, which, you know, back from high school geometry, you may remember is pi r squared. And we multiply it by the velocity, and we use Doppler to measure the velocity. But the first step is actually measuring the LVOT diameter so we can determine the radius, which would be the diameter divided by 2. So the way we do that is we go into our parasternal long axis view. You want to get the prettiest looking parasternal long axis view you can get. And specifically, you want the LVOT to be as pretty and crisp as possible, okay? So you want to optimize your angle, optimize your rotation, all those things. And sometimes zooming in on the LVOT can help as well. Sometimes it doesn't help, but sometimes it does. So you can give that a try as well. But what you do is you get your prettiest looking long axis view and you freeze it. And you use your gain knob or your finger on the trackpad to move back and forth. And you want to move to when the LV is in systole, meaning when the aortic valve is widest open. So this is the peak part of systole. Okay, so you want to scroll to when that aortic valve is wide open, and then you want to find the aortic annulus, or the hinge point of the aortic valve, which is here. You can see, and up here, and just back up a tiny bit, maybe a millimeter or so, and measure the diameter at that spot there. Okay. The good thing is the diameter between the aortic annulus and the mitral annulus here is fairly constant, or is constant. So as long as you're measuring somewhere between the aortic annulus and the mitral annulus, you should be okay. But I like to use the aortic annulus as a marker, as a landmark, and I'll show you why as we go forward. So you find that, back up a little bit, measure the diameter there. Okay. The convenient thing is in the average sized, patient, average sized male patient, 70-kilo male patient, the LVOT diameter is 2 centimeters. So the R is 1. So really pi r squared is just pi. Okay. So that's the diameter / radius piece. In order to measure the velocity, the second part of Poiseuille's law, Poiseuille's equation, we use Doppler. So remember we said we use pulse wave Doppler and we put it at the LVOT. Okay, but we cannot measure velocity in this view, right? Because blood is going this way, which is going to be perpendicular to your sound wave. Okay, so we have to go into a view where the blood flow is parallel, or as parallel as possible, to the Doppler beam. So it has to be in one of the apical views where the aortic valve and LVOT are visible. So that means either the apical 5-chamber view, which is basically the apical 4-chamber view angled anteriorly, so you bring in the aortic valve, or what's called the apical 3-chamber view, which is basically a rotated apical 4. So you get into your apical 4-chamber view, and you're going to rotate the probe counterclockwise so that the dot starts to point up towards the left shoulder. And what will happen is as you rotate, the apical 4-chamber view will become the apical 2 as the RV hides behind the LV. As you rotate even more, what will happen is the aortic valve and the LVOT will appear on screen right of the LV. So that is your apical 3 chamber view. Okay, so the fifth chamber, so to speak, in the apical 5, or the third chamber, so to speak, in your apical 3, that's the LVOT. Okay. So here's what our apical 5 chamber view looks like. So it's your 4 chamber view, angled anteriorly a little bit. Here's your LV. There's your aortic valve, and there's the proximal aorta. So this is your LVOT here. You get this view. And like I said before, angle is really important with Doppler. So this is why getting an on-axis apical 4-chamber view is extremely important, especially when you're using Doppler, because as the angle changes, as your theta angle changes, your velocity measurements are going to be less and less accurate. And when you get to a theta angle greater than 30 degrees, they're going to be clinically significantly inaccurate. Okay, so remember, angle is important. You want an apical 4-chamber view where you're at the apex and where your septum is straight up and down. So when you angle into the 5-chamber, your angle into the LVOT will be as parallel as possible with your Doppler line. Okay? So I'll show you what that means. So you get this view, press Doppler, and you're going to select pulsed wave Doppler. When you select pulsed wave Doppler, you're going to get this line here with a little bracket in the middle. Okay, this line is telling you this is the direction that the sound wave is being pulsed into the tissue at. So this is the direction of your Doppler beam. And you can move this left and right. Okay, so the first thing you want to do when you turn it on, you're going to align this beam by moving your finger left and right. And you want to align this beam so that this beam is as parallel to the blood flow through the LVOT as possible. So that's your first step. Okay, and again, you can see how making that septum vertical is going to make this angle as parallel as possible. Really important. Okay, the more off angle you are, the less and less accurate your velocity measurement is going to be. Okay, so turn on your Doppler beam, align it to be as parallel as possible. The next thing you're going to do is you're going to position this bracket. So this bracket is your sampling volume. This little bracket is telling you that the machine is going to measure the velocity here in this bracket here. So what you want to do is you want to position this bracket in the LVOT. Now remember I said when you measure your LVOT diameter, you find the aortic annulus, the hinge point of the aortic valve, and back up 1 millimeter or so and measure the diameter there. What you're trying to do is you're trying to measure the velocity at the same place where you measured the diameter of the LVOT. So what you want to do is you want to find the aortic annulus, the hinge point of the aortic valve, and position this bracket just above that, about 1 millimeter or so up from there. Okay, so I would actually move this down just a little bit more than what's pictured on this image here. So move this bracket so that it's positioned in the LVOT, just proximal to the aortic annulus. Okay, the third thing you can do is you can, this is optional, you can use an angle correct feature. So what you do is you activate the angle correction on the smaller machines, on the Edge and Edge 2 machines, you're going to hit select. On the export, you're actually just going to tap right in the center on the screen of your Doppler line here, and that will bring up the second line. The second line is an angle correction line, and then what you do is you move your finger left and right to rotate this line. And you want to position this line to be parallel to the blood flow. So if you can imagine, as blood is being pushed through the LVOT, it's going to go in this direction. So you want to align this to be about parallel to that wall there of the LVOT. So position that angle correction there. And this is going to do two things for you. First thing it's going to do, it's going to tell you what the theta angle is. So this is going to tell you the angle between your Doppler beam and the direction that you imagine blood flow going through. So this is 14 degrees. So it tells you, number one, what your theta angle is, and it tells you whether your theta angle is too big or not. In this case, it's under 30, so we're good. The second thing it does is it will plug this number into the velocity, the Doppler equation, to get you a tiny bit more precise of a velocity measurement than if you did not use the angle correction. Okay, some people use it, some people don't. I mean, if you're fairly close to being, parallel, there's probably no point in doing it. If you're way off, then no amount of angle correction is going to give you a usable waveform. So some people just don't use it altogether. I use it just because I like to add a little bit of precision to my measurement. Okay, so you aligned your beam, you positioned your sampling bracket. and then you've done your angle correction if you want to, and then you press Doppler or press start, and you're going to get a waveform. What you're going to get is a velocity time waveform, and this is velocity of blood moving down, okay, because blood in this case is going to be moving down through the LVOT. So what you're looking at here is you're looking at a tracing of blood flow velocity on the y-axis over time. So this is the velocity time curve of blood being ejected out of the LVOT, okay? So you can see that as the LV pushes blood out, you get acceleration, rapid acceleration to a peak velocity, and a less than rapid deceleration to the end of systole. And then you see this little spike here. This spike is the aortic valve snapping shut, okay? Notice that there is a spike, a closure spike, the aortic valve snapping shut, but there is no opening spike. You're not seeing the aortic valve opening. And the reason for that has to do with the position of your sampling bracket. This is telling you, because you're seeing a closing click and not an opening click, this is confirming for you that your sampling volume, your sampling bracket is above the valve, is proximal to the valve, okay? Because as the valve closes, it's going to transmit a pressure wave back up toward the sampling bracket. That's going to be detected by the sampling bracket, okay? But the opening of the aortic valve, the pressure wave generated by that is going to be blown downward. So you're not detecting it. Okay, so this is sort of another way of confirming that your sampling volume is in the right place. Your sampling bracket is in the right place, that's above the valve. Okay? If you turn on Doppler and you're starting to see a spike here, that suggests that for one reason or another, your sampling bracket has descended below the valve, which is not where you want to be. You want to be above the valve, okay? So sort of look at this curve. This is what your curve should look like, knife-shaped, much longer than it is wide, rapid acceleration to a peak, deceleration, closing click, no opening click, okay? Velocity time curve of blood going out of the LVOT, okay? So what we're gonna do is we're going to then press, we're gonna freeze this. As you get more and more comfortable with these and any other measurement, you wanna be doing all of these measurements in expiration, because again, that's sort of the convention in critical care is all hemodynamic measurements should be in expiration. It is theoretically possible that you can have significant respiratory variation. And so since a lot of what we use stroke volume for is to look at change in stroke volume, you want to make sure that your before and after measurements are being done in the same part of the respiratory cycle. Okay, so expiration is what you're going for, freeze it. You're going to hit your calc, select AV for aortic valve and LVOT VTI. Okay, now VTI stands for velocity time integral. If you remember back from high school calculus, you remember that the integral in calculus is the area under a curve. So your VTI is the area under your velocity time curve, okay? So you'll turn that on. That's gonna give you little crosshairs. You're gonna bring that to the beginning of your waveform, and you're going to trace this waveform freehand up to the closing click. And when you hit set, you're going to get a bunch of numbers here. The number we're interested in is the VTI, the velocity time integral, or the area under that curve. Okay. In a person with an LVOT diameter around 2, with a relatively normal heart rate, not tachycardic, not bradycardic, a VTI of about 18 correlates with a normal stroke volume. Okay. So if we do our math, our LVOT diameter was 2.01. So R is 2.01 divided by 2, pi r squared, times our VTI, which is 20. That gives us a stroke volume of 65 cc's. We can then go back, and if we go down to main, it'll give us an option for heart rate, and that will give you 2 lines, and you want to put one line at the beginning of one curve and another line at the beginning of the next curve, and that will give you your heart rate. You can plug that in to get your cardiac output. And if you actually input the patient's height and weight in the machine under the patient information page, it will actually give you a cardiac index as well by dividing by body surface area. Okay. Most of the time, the number we're interested in usually is just the stroke volume. But if we're doing interventions and heart rate changes, then we want to use cardiac output to account for changes in heart rate. Okay. And sometimes, yes, knowing the cardiac index is helpful for us. So again, the accuracy of your Doppler measurements are very, very directly dependent on the optimization of your 2D views. And by optimization, in reference to Doppler, it's all about the angles. Okay, so you don't necessarily need to have a crisp view of the endocardial border of the LV and so on, but what you want to have is an on-axis view, a truly apical view with the septum being vertical, because that's going to help you optimize your angles. Okay. Measurement of the LVOT diameter is also very important, because remember, you're squaring this number, or at least the radius. And so any error that you have is going to be squared. So remember to get as pretty an LVOT view as possible, and be very careful when you're measuring the diameter. You want to measure from blood tissue interface to blood tissue interface, perpendicular to the actual track of the LVOT. Okay. And like I said, use end expiratory VTIs, because we're looking before and after in a lot of these things. And if you want to be really precise, just like you would do with thermodilution, get like 3 to 5 measurements and then average them. If you really want to know what if you're really trying to, get an idea what the cardiac index is, do it this way, just like you would do with a PA catheter. Okay. The pitfalls, again, sort of the opposite of the pearls. Bad views, bad angles will get you bad velocities. Again, any patient that has evidence of LVOT HCM, don't use this in, because you're not going to get accurate numbers. And we'll talk again in the HCM specific talk how to screen for that. And just like any Doppler, sort of modality, if you're getting a lot of cardiac translational movement as the patient breathes, for example, what's going to be happening is as the heart swings left and right, your theta angle is going to be changing every time that heart swings. So your measurement every time that theta angle moves is going to be different each time. So that will add some error to your measurements. Okay. How valid is this? Well, back in the late 70s, early 80s, mid 80s, there were a number of small studies that correlated Doppler, stroke volume, and cardiac output measurements to thermodilution as sort of a gold standard, both in terms of accuracy, so actual numbers, and precision, which means trends. And then there were a number of larger studies that sort of confirmed what was found in the smaller studies. The one of the studies that's, I think, quoted the most is this one from '88 from Intensive Care Medicine, where they looked at 116 critically ill patients who had PA catheters in place. And they just basically compared the thermodilution, stroke volume, and cardiac output measurements they got with the Doppler measurements. And they found that there was good correlation, again, with the absolute value. So that means the stroke volume, cardiac output itself is accurate, and in the precision. So the trends are just as usable as well. Okay. So again, why are we trying to quantify LV function? Like I said, most often we're trying to gauge the response to therapy or predict a response to therapy. So I want to talk about that first one. I think predicting volume responsiveness using more often the passive leg raise with Doppler stroke volume is, I think, the most commonly used application for this, especially in like a general critical care setting. And we know what volume responsiveness is. We know that it's the state in which volume resuscitation will increase stroke volume and cardiac output. Okay, and oftentimes the most important step in resuscitation is determining whether someone is going to respond to volume or not. And in many patients, just doing a volume challenge is fine. But if you have a patient that would potentially get worse with a volume bolus, like someone with underlying heart failure, someone underlying pulmonary hypertension, someone who may already be volume overloaded, then predicting response to volume is probably a safer approach than giving a volume challenge and seeing what happens. Okay, and we've talked about some of the predictors of volume responsiveness, but I want to talk about the ones that are pertinent to stroke volume. The first one is stroke volume variation, where basically you're looking at the effect that respiration is having on stroke volume. In patients who are volume responsive, pleural pressure changes that come from breathing in and out will cause significant changes in your stroke volume. So that's called stroke volume variation. Okay, and the way you calculate stroke volume variation is you would measure the maximum stroke volume and the minimum stroke volume, and depending on your patient, depending on whether they're on the vent or not, that will either be in inspiration or expiration, but you want to measure both, and you want to get the difference between the two and divide by the mean, the mathematical mean of the two. And that will give you your stroke volume variation, okay? And you know that a stroke volume variation of more than 13% is predictive of volume responsiveness. But remember, you have to meet 4 prerequisites in order for you to be able to use this number. 1, you have to be intubated on the vent, and you have to be passive on the vent, on conventional mechanical ventilation. So you can't be triggering, at least not all the time, or at least not most of the time, you should not be triggering the vent. Most studies have been done in patients who are on 8 cc's per kilo body weight tidal volume. There are some studies in patients with poor lung compliance that are on 6 cc's per kilo, but most studies are on 8 cc's per kilo volume control. Okay, they have to be in a regular cardiac rhythm. Okay, so any sort of irregularity like AFib or any other sort of atrial tachycardia could invalidate this because irregular rhythms by in and of themselves cause stroke volume variation. And finally, you have to have a normal RV. So you can't have RV strain, can't have RV failure. Okay, so if you look at all the patients in the ICU, there are probably not a whole lot that meet these criteria. Okay, the situation where you could use this most often is someone who is paralyzed for one reason or another. They have bad ARDS, so they're paralyzed, or what have you, or you just intubate them using a long-acting paralytic. You could use this as a predictor of volume responsiveness. Okay, but in everybody else, it's not very widely applicable. And basically what you would do to do this is you would get your Doppler measurement and you would slow down your sweep speed so you get a bunch of different VTIs. And you're going to measure the biggest VTI and then the smallest VTI, subtract and divide by the mean, and that will give you your stroke volume variation. Okay. In this case, it's about 18%. Okay, so this is a patient, if they fit those 4 prerequisites, that would be volume responsive. Okay. So just do the VTI of this and the VTI of that. You don't have to do the full stroke volume calculation because the only thing that's changing here really is the VTI. The LVOT diameter is not going to change. So you can just use VTI. Okay. The modality, though, that I think is more useful is passive leg raise. And I think you know the principle behind the passive leg raise. The idea is that you're taking pooled blood that's in the lower extremity venous system, and by raising the legs, you're redistributing that blood back into central circulation. So it's almost like you're giving a intrinsic fluid bolus, a fluid challenge, okay? And the best way to do a passive leg raise is to see if the stroke volume increased with your passive leg raise, okay? And what has been, found as the way to do this is if your stroke volume increases by at least, they say 12, but at least 12 to 15%, with the passive leg raise, the patient is very likely to be volume responsive. Okay, so how do you do this? You basically start with the patient head up, legs down, so 45 degrees head up, measure your VTI. And again, you don't need to do the whole stroke volume calculation. You don't necessarily need to measure the LVOT diameter because that's not going to change with a passive leg raise. The thing that's going to change, if anything, is the VTI. So you really just need to measure the VTI with the head up and legs down. Drop the head, raise the legs, wait at least 6 to 10 beats, and then repeat your VTI. Okay. If the VTI went up by 12 to 15%, then they're going to be very likely to be volume responsive. Okay. Again, the advantage of this, it's essentially a reversible fluid challenge. So if the patient doesn't like it, just drop the legs and sort of take it back, at least eventually take it back. It's equally as reliable in patients on the vent on positive pressure and those that are spontaneously breathing. Those who have irregular rhythms and those who have regular rhythms, it's usable in all these patients, okay? The main limitations are if you are so hypovolemic or so vasoconstricted that you don't have a lot of pooled blood in your lower extremities, then you may not get the fluid challenge that you're looking for, and you may potentially miss a patient who's volume responsive, okay? So if they're on high-dose vasopressors or if they're hemorrhaging, this may not be a method that's very predictive, okay? Intra-abdominal hypertension is another thing that can get in the way, of course, because the blood has to go from the legs through the abdominal compartment into the heart. If you have high IAP, then that blood may not get back, or at least not as rapidly as would need be for a passive leg raise. So that's another potential limitation. Obviously, if you're a lower extremity amputee, that can get in the way as well. Okay. So that is predicting volume responsiveness. Very useful application for stroke volume here. Okay. The next step, so say you've done your prediction, you've determined the patient is volume responsive, you can then use stroke volume change to help you determine how much is enough. So how much volume is enough. The same thing you can do with inotropes, the same thing you can do with diuresis, okay? So as you're doing your intervention, you continually check to make sure that you're getting the increase in stroke volume that you're looking for with your intervention, okay? So here's an example of a patient who has underlying heart failure with poor EF, in septic shock, who is hypotensive, passive leg raise was positive, but this is someone who could be potentially tenuous from a volume standpoint. They could go from liking volume to hating volume very quickly. So you'd want to take a more measured approach in deciding how much volume to give. And so what you can do is something like this. This is almost like creating a Starling curve for your patient. So in this patient, we used cardiac output because the heart rate was changing, of course, as you resuscitate the patient. So you want to do the full cardiac output calculation. So after the first liter, the cardiac output went up from 5 to 6.2, about a 25% increase. After the second liter, it went up by 17%. After the third liter, it went up by another 10%. And these are additive from the previous measurement, okay? After the fourth liter, no real change. So you can imagine that here you're on your ascending part of your Starling curve, your slope is starting to drop, and then finally you plateau. So now you're on your flat portion of Starling curve. There would be no added benefit, hemodynamic benefit to giving more fluid. All you will do at this point is increase the risk of bad stuff. So at this point, you want to reevaluate your cardiac function, see if they need inotropes or what have you, and then use vasopressors. Okay, so this is a good way of not going too overboard with your fluids, but giving enough that you're getting the response that you want. Okay, creating a patient-specific Starling curve. Can do the same thing with other things like inotropes. So this is another patient in whom we started dobutamine, and you can see that the cardiac output from 0 mics per kilo per minute of dobutamine all the way up to 7.5 gets you a pretty appreciably large increase in cardiac output. When you hit 10, from 7.5 to 10, it doesn't change all that much. So you've kind of plateaued here. So this is another way of helping you titrate things like inotropes. And of course, this is not the only thing you're looking at. You're using this as sort of an early data point, and you're going to integrate with other things like urine output and lactate clearance and SCVO2 and all those other things. Okay, but you will sort of be able to determine the optimal dose of your dobutamine, for example, before your repeat SCVO2 or before your repeat lactate comes back. Okay, so this is sort of an early data point. So clearly, being able to measure stroke volume and cardiac output helps us in a number of ways. But what if you can't get the apical view? Are there other ways that you can, sort of quantitate LV function? And the sort of answer is yes/maybe. And one of the ways is by using ejection fraction analogues or ways of quantifying ejection fraction. There's a couple of methods available to us as intensivists. One is what's called fractional volume change, or the Simpson method, but that requires a good apical view. So if you can't get an apical view to do stroke volume, you're not going to be able to get an apical view good enough to do your fractional volume change. Or if you can get a good enough apical view to do Simpson method, you can probably get enough to do a stroke volume. So what I'm going to talk about is actually the fractional area change, which you can do from your personal short axis view. Fractional area change is basically the change in ventricular area in systole versus diastole. And what you're doing is you're getting a mid-papillary short axis view, and you're measuring the sort of area using the machine, and you are looking at it in systole and diastole. You're subtracting the difference between the two areas and dividing it by your diastolic area. That gets you your fractional area change, or the change in your left ventricular area in systole versus diastole. So this is how you would do it. You want to get your mid-papillary view, and first you want to freeze it and scroll to when it's wide open in diastole, and you're going to trace that. And notice you're excluding the papillary muscles as you trace it. You'll get that area. You then scroll to when the ventricle is in systole, when it's at its smallest, and you trace that area, and you plug it into your equation there. diastolic area minus the systolic area divided by the diastolic area. That gets you your fractional area change. Okay, and this is used, at least conventionally, as a poor man's ejection fraction. There are tables out there that correlate fractional area change with EF. Here's an example of one of them. Okay, remember, of course, the limitations. This is a two-dimensional measurement of a three-dimensional structure. So there's a lot of potential error there. And you're looking at a small region of the LV. So if you have focal wall motion abnormalities, that may not be taken into account by this measurement. Okay, but the reason why we're doing this is to look at change anyway in response to some sort of intervention. So these are, while these are still important limitations, they're not as important as if you were using it to say the EF is 42%. Okay. So how do we use this clinically? There's really two ways we can use it. One is just by looking at how much the fractional area change improves after an intervention, either with volume or inotropes or so on. And you can also look at what's called LVEDA variation. Let's talk about the first one, fractional area change. So the theory behind this is that if you have a volume responsive heart, because of Starling's law, if you give that volume responsive patient that volume responsive heart volume, your fractional area change should improve after a volume bolus. Okay? So if you see improvement in fractional area change with a passive leg raise, for example, that may be a way of saying this patient is likely volume responsive. Okay. Same thing you can do with inotropes. You want to see that your fractional area change is improving after giving inotropes. Okay. So you're trying to measure the response or titrate intervention. Clearly, this is not as good as looking at change in VTI or change in stroke volume, but it's sort of a poor man's method. If you cannot get your apical views, if you cannot get your Doppler interrogation of the LVOT to get your stroke volume measurement, you can at least use this as sort of a semi-quantitation of LV function. Okay. So does the fractional area change improve with passive leg raise? Does it improve when I add my dobutamine? And when I titrate my dobutamine, this is how you can use it. Okay. In much the same way you can use stroke volume variation, you can use what's called LVEDA variation in the select patient to help you predict volume responsiveness. Using the same way as stroke volume variation, you get the biggest LVED area subtracted from the smallest LVED area. And this is all end diastolic area, so you're looking at diastole, and divided by the mean of the two. So what you're doing is you're looking at the end diastolic area in inspiration and the end diastolic area in expiration. And if there's a significant amount of variation between the two, that is suggestive of stroke volume variation, which is suggestive of volume responsiveness. But remember, you have to meet those four prerequisites in order to do this. Passive on the vent, ideally 8 cc's per kilo tidal volume, regular cardiac rhythm, normal RV. So not super generalizable, but in the same way you can use stroke volume variation, you can use LV and diastolic area variation to help you predict volume response. Okay. So again, neither of these are nearly as good as using stroke volume as a way to quantify LV function. But if you cannot get the views to do stroke volume, then you can use fractional area change or LVEDA variation. As always, if you have questions, come and find me or shoot me an email. Otherwise, I look forward to